Hi, everyone. Welcome, welcome. We're letting folks start trickle in. So if you are just now joining, you're in the right place, and we're glad that you're here. We're going to give it just a minute or two because sometimes Zoom takes a bit for the webinar feed to get rolling and get going. So we'll let folks arrive, but so you've got another minute if you want to pour a cup of tea or coffee or just sit back and relax for a minute. You're in the right place, and we're glad you're here. Again, thanks to everybody who is on and joining. The numbers are rolling in as folks are finding their way to the webinar. We're glad that you're here. We're at a minute past the hour, and we're just going to give it 30 more seconds for folks to trickle in and to join us. But we're glad that you're here, and you are in the right place if you're here for the End of Life New Mexico and Compassion and Choices webinar. All right. Well, let's go ahead and we'll start with some housekeeping so that we're respectful of folks' time and so that we can get going here. I'm excited to have all of you here and to get to kind of moderate today. My name is Matt Whitaker. I'm the National Director of Integrated Programs at Compassion and Choices, and excited to be the one who gets to introduce our panel to you and to work through some of the questions that we have at the end of today's presentation. We're glad that you're here, and we're glad that you're interested in this topic. Before we begin, I always like to kind of remind ourselves of the fact that we're talking about a practice, but when we're talking about this practice, we're talking about people and families and all of the folks that are connected to the folks who are making these decisions that we talk about. So before we get started with kind of our general housekeeping, I wonder if you'd join me in just kind of taking a breath, settling into the moment, seeing if we can kind of forget about some of the pieces that are going on in the background and focus our attention on those people that we are here because we want to help. So let's take a big deep breath in together and out. And again, just take a moment to remember why it is that we're here and why it is that we care about this work. Thank you. So again, you're at the Pharmacology and Clinical Competencies of Medical Aid in Dying presentation. Today, I'm very excited to get to introduce our presenters. First, I want to say that we're unable to be joined by Representative Debbie Armstrong. In her stead, we have Barrick Wolf from End of Life New Mexico, but we want to take a moment and recognize Debbie for the giant that she has been in making the End of Life Options Act in New Mexico a reality. Without her, it would not have been possible. And so again, while we're not joined by her today, we want to make sure that we're recognizing her today. The updates that you'll be hearing today are from her voice and from her experience as a person who's been on the front lines of this issue. We are also joined by Dr. David Grube, who is our National Medical Director at Compassion Choices. Dr. Grube came to Compassion Choices after an incredible practice in Oregon, in Philomath, Oregon, where he provided primary care and family medicine to people through the whole spectrum of their life, from children to those who were facing these end-of-life decisions. We are lucky now to have him at Compassion and Choices, where he serves as an educator across the country, again, helping people and physicians and clinicians who are trying to learn all of these various pieces around end-of-life care. So we're so glad to have Dr. Grube with us. And then finally, we have Susan Gess with us, who is the drug education coordinator with Kaiser Permanente. And I've been so fortunate to get to watch Susan present on this topic many times. And I think, as you will find, like I have, that her background is not only as someone who's incredibly knowledgeable about this option and about all of the competencies that are involved, but also is one of a very heart-forward person who cares deeply about the people that she serves. And I know that will come through today. And so we're so lucky, so fortunate to have her on the call to share her experience and to share her heart with all of us. A couple of housekeeping pieces, as well as just to go over the learning objectives. Today's webinar is being recorded, and so you are in kind of a listen only mode so that we can make sure that we retain that recording, and also that we retain your privacy as we ask questions and things like that, since this will be published on the internet afterwards. So if you have questions throughout the presentation, the best way to make sure those get addressed is to type those in the Q&A box that you'll see on your Zoom browser. We will compile those, look for trends, make sure that we're kind of asking the best questions possible to answer as many as possible at the end, and answer those at the end of the presentation. So feel free to drop those in at any moment throughout today, and we'll make sure that we hopefully have time to get to those. Also, if you are wanting to access CME credit, everyone who's attending today will get a certificate of attendance on Friday, so look for those in your inbox then. But if you are specifically trying to get continuing medical education, it's a different certificate that we send you. So if you'll just say that in the message box, we'll record that name and make sure you get the appropriate certificate. Finally, now I'm going to go ahead and turn things over to Dr. David Grube, who will kick things off and start us up. Or actually, sorry, let me make sure I'm correct in who I'm turning it over to. I'm turning it over, yes, to Dr. Grube to talk us through options at the end of life. And then I will see you during the Q&A portion of today's presentation. Thank you. And Dr. Grube, take it away.
Thank you, Matt. And I'm very, very happy to be here with you today. Just a few things I want to say in the beginning. The reason that we're here to talk about this topic is it has been, as Atul Gawande said in his wonderful book, Being Mortal, a lot more complicated to die in America and it will be increasingly more with the extremely wonderful high-tech medicine that we can provide. It gives us more options, but it gets it more complicated. And some of these deaths then do become prolonged, and there becomes intolerable terminal suffering, which is what we're talking about really today in the end. Next slide, please. I just want to remind you and redefine for you what medical aid in dying is. The components are that the individual themselves has to have capacity. They have to be volitional, and they have to be an adult and a resident of your state to ask their provider. In New Mexico, could be allopathic or osteopathic physician, advanced practice registered nurse, or physician assistant, to get a prescription of the medication that Dr. Gess is going to outline, to self-ingest to end their intolerable terminal suffering. And so there are now in America many, many end-of-life options. The default, of course, most of the time is to do everything for everybody all the time. But we have these other options, which I won't read through, but we're focusing today on the last one, medical aid in dying. Next slide, please. And we want to dispel some myths about medical aid in dying, which I hope that you'll understand after the presentation today. It is not true that it is always simple and easy to access this. Now, New Mexico's law is better than any other states, and that's good. But nevertheless, there will be some access issues and problems. It is not true that aid in dying is a failure of palliative care or hospice care. Indeed, it's a component, it's an option, it's a choice in the palette of end-of-life care. It is not suicide, and we're going to talk about language a bit also today. And it's also not possible for any of you who are clinicians, palliative care physicians, end-of-life physicians. It is not always possible to assuage terminal suffering. Next slide. Language matters. This brings home to me almost every single day how important it is that we use kind language, non-judgmental language, language that does not cause guilt or shame, and to be professional as we're speaking to individuals who are dying in these arenas. Even if we are opposed to aid in dying, we need to be kind and use language that is appropriate. Next slide, please. And it's clear in those who practice aid in dying that this is not a suicide. Those who choose to aid in dying want to live, but they cannot. Their life is about to end. They want to plan their death with their family, with their loved ones. This is not impulsive. This is something that's been well thought out. And they have capacity. They know what they want and what they are doing, as opposed to individuals who suicide generally have some kind of severe mental illness, whether it's addiction, PTSD, major depressive disorder, etc. And they don't have a terminal diagnosis. Usually, they are not wanting to live when they could. And then ultimately and importantly, after the death of the individual, those who choose aid in dying, the grief reaction with the family member and the individuals who are loved ones who are left over, their grief is in the normal category. Whereas those of us who had a patient who suicided know that the grief is not normal, that even the clinical team has a sadness and wonders what we could have done to have recognized that this individual chose to take their life when they could live. Next slide, please. New Mexico becomes the 11th jurisdiction. 9 other states and the District of Columbia are states where aid in dying is now an end-of-life option. They're here in this blue slide, and I want to make a comment that over 20% of individuals in the United States now have this option. All right, I'm going to turn it over to Mr. Wolf now to give some information about the Elizabeth Whitefield End of Life Option Act. Then I'll be back briefly to talk about a little bit of the history of the pharmacology, but we'll then get into the real core of this presentation with Dr. Gess.
Well, thanks so much, Dr. Grube and the folks from Compassionate Choices. Barack Wolf here, and I've got some big shoes to fill in for Debbie Armstrong, who is absolutely a champion's champion. What I loved about Debbie is her ability to get deep into the weeds of our bill for the last number of years, and also bring her incredible and passionate advocacy to the work. She has a compelling personal story with an adult daughter who has lived on the edge for many years with her cancer, and it continues to be a struggle. So big shoes to fill, but it's an honor to be here as the chair of End of Life Options New Mexico. Next slide, and we'll just get right to it because we want to get to the meat of today. Again, Elizabeth Whitefield, Dr. Grube just went over the definition. There's nothing really different in our definition. We passed the law this last session. It was signed by the governor in April and went into effect June 18th, really, 5 months ago. And just a word, if I could, about Elizabeth Whitefield. A family court judge, well known in Albuquerque, suffered a very tough cancer, and yet was an enormous advocate for end-of-life options. Here in 2017, with her trach and her oxygen, she would stand up in front of the committees and address the legislators, who many of them she knew well, and tell them why they needed to pass this law. Didn't happen in 2017. Summer 2018, she died a very tough death. And we knew that when we got to 2019 that we would honor Elizabeth by naming our act on her behalf. Next slide. So, Dr. Grube already mentioned eligibility, and this is common in all 10 states and New Mexico. We didn't do really anything terribly different here in our bill. Have to be an adult. This is not for children. Have to be a resident of New Mexico. I'd mention that we don't define residency in our bill. So, it's fairly open-ended and ultimately gets to be decided by the provider and the patient themselves. And, we can give some guidance, but it's pretty open-ended. In terms of terminally ill with a prognosis of 6 months or less, again, our language is very clear. It's a disease or condition that is incurable and irreversible in the best reasonable medical judgment. So very straightforward. We're going to talk a little bit more about capacity. Yes, it has to be an informed, the individual has to have the ability to make an informed healthcare decision, and they must be able to self-administer the medications. Again, the same in all states. We're pretty clear also about self-administration, that there can be some help involved here. It has to be an affirmative, conscious, voluntary action to ingest the medications, which means going into the digestive tract, which means for those who have difficulty swallowing, we can use a feeding tube or rectal administration, and they can get some help along the way as long as we meet those criteria. Next slide, please. And here's where we start to vary a little bit. Dr. Grube mentioned that in addition to the medical and osteopathic physicians, here in New Mexico, it just was clear that if we're going to reach and provide access in our rural areas, we really have a long history and supportive legislation of using mid-level providers fully. And so both advanced practice nurses and physician's assistant are allowed to either be consulting clinicians or even prescribing clinicians, because they have that ability here in New Mexico, so that we could expand access. Now, there were some, and we'll get to the next slide where we talk about provider involvement. And you'll see that there are some caveats around that in every case, there has to be an MD or DO, next slide please, who can make a full assessment of the patient. So if you have a mid-level provider who's doing the prescribing, then the clinician, MD or DO, must also do a full exam. That was part of a compromise that comes out of the legislative process. So one physician must determine the patient is qualified, can either be the consulting or the prescribing. We also have something in our law that's really what we call our hospice exception. And I think we're the first ones so far to actually put in law that if someone is enrolled in hospice, then that really affirms their qualification with their 6-month prognosis. And it can really move forward the process as appropriate by not necessarily having an additional consulting clinician. And that ties into really one of the most robust innovations in the next slide, which is really about the fact that one of the major hurdles in other states has been the lengthy process involved in obtaining the medications. So we basically went for a shorter waiting period here in New Mexico, and that is between the time that the prescription is written by the prescribing clinician and that it can be filled by the pharmacist. There's a 48-hour waiting period. And that is really the only waiting period. Now, that doesn't mean it's not going to take time. Of course, we're going to do the good job and do the good assessments, including, if necessary, a mental health referral for those where there's a question about their capacity. But we're going to move the process forward as rapidly and accessibly as we can. And also, like other states now, the 48-hour waiting period can also be waived. Next slide, please. So just wanted to let folks know that in the rest of our bill, we have a lot of protections for all parties involved. It's entirely voluntary. No one has to do any of this. There's no duty to participate. As long as people are acting in good faith under the act, whether that's the medical team or the family or a friend who attends the death, everybody is protected from liability concerns. It is clearly not assisting suicide, and I think that's very important. Our law specifies aid in dying is not suicide, and that facilitates a lot of improvement when it comes to the death certificate. What's going to be on there is the underlying condition and those kinds of issues. And the clinicians are also provided protection from any criminal liability as long as they're participating or not participating. It doesn't matter. We protect all parties in this. And the final thing I'll mention about our law is that we also include a right to know. We feel that all people ought to understand their end-of-life options, and we request and require in the law that as people have serious illness or towards the end of life, that their clinicians have an obligation under this law to speak to them about all of their options, whether they themselves are going to provide them or not. And then if they're not going to provide them, we expect them, and the law expects them, to make a referral either to a clinician that will assist or to an organization like ours that can help effect that referral. So we can cover more in the Q&A, and there's certainly more. You see our website at the bottom of every slide. We have an enormous amount of information on there with a lot of the specifics. So let me hand this back to Dr. Grube, and we'll get on with the pharmacology.
Thank you very much, Mr. Wolf. Next slide, please. Yeah, so we're going to talk just a few little basic things before the pharmacist actually gets to the core of it. But the medicine is ingested, as Mr. Wolf said. It is self-ingested, so it's never injected. There is no specific law in any state, New Mexico included, for an exact mixture, but there are standards, and we're going to cover what the standards and the typical prescription would be. It must come from a compounding pharmacy, which is not just a regular retail pharmacy, but a compounding pharmacy, and there aren't too many of those in New Mexico. It can come as a powder or it can come as a liquid. And as I mentioned, only ingestion can be used, but ingestion can include a nasogastric tube, a stomach tube, feeding tube, or a rectal catheter if the individual is not able to swallow or is having active vomiting. But the point is that the patient herself or himself must initiate the act of ingestion themselves. That's very, very important. The medicine should be swallowed quickly so the individual does not fall asleep. Quickly is generally within 90 seconds. It's only 4 ounces, so that should be possible. And the time to falling asleep or loss of consciousness is generally between 5 and 10 minutes. Times can be up towards of 20 minutes. And then they will, almost all of them will die within an hour to an hour and a half, although we always have to be prepared for outliers who might be quiet and peacefully lying there, but their death may not come for a couple hours. Next slide, please. Now, this is a very busy slide, and I just want to quickly go over the fact that you might have heard that cetobarbital or pentobarbital are used, and that has been historically the case until they became no longer available in the US. And so since 2019, that has not been possible. There were groups of clinicians, including pharmacists, who went through some various different protocols with different kinds of medication, and ultimately have come to the idea now that probably the best combination of medications is a thing called DDMA P(h). Next slide, please. Again, these protocols went through the different years, but finally, through the research and work with particularly Dr. Woods in Washington and Dr. Shavelson in California, DDMA PH is probably the best standard. And Dr. Gess is going to go through those with you in just a second. Next slide, please. The information about these medications can be obtained at End of Life Options New Mexico, or other areas. Compassion and Choices can provide that, as well as the American Clinicians Academy on Medical Aid in Dying, ACMAID. This is the list of the medications, but we're going to go through that more closely in a few minutes. Next slide. The amitriptyline component in about 10% of cases may cause some burning. So it's a good idea to have something soothing on hand if that's the case before the patient falls asleep. Typically, it would be a sorbet of a flavor of their choice. It's really important to remind them to not to stop as they're taking the ingestion, but to keep on swallowing, so then the sorbet can be delivered. This is administered by the family, and that loving gift of a last final taste of their own flavor is important. So, I'll say with this one last thing. Yeah, you can go ahead there. I'm going to actually turn it over then to Dr. Gess, so that she can talk about the next slides.
Hi, everybody. My name is Susan Gess. I'm a pharmacist in California, and you can stay where you are. Thanks, Matt. We've had the law since 2016, so we're not far behind you. It feels like, we've just started this journey with you. Just transitioning to the idea of the DDMA or DDMA PH, as pharmacists out there, as I assume many of you are, part of your job will be to advise physicians who call and say, gosh, what should I use? I've seen these various preparations available. What are the pros and cons? So it's really nice that you have some education about that. Some areas still use DDMA, and some people add the Phenobarb on top, so it becomes DDMA PH. So the difference between those two is a difference in time to death of 2 hours with DDMA versus probably 1 hour with the Phenobarb. That extra phenobarbital seems to help constrain the time to death. They still both have the same time to loss of consciousness, and it just helps the family know that they won't be sitting there as long waiting for time to death. Now, this is, again, we mentioned before, you can't promise that the time to death will be around 2 or 1 hour, because there are these red flags, these situations that create the outliers. And the next slide will summarize that. So some of the issues, if you have a patient with stomach cancer, they've had resections, they have any kind of dysfunction of the bowels, that GI or absorption is going to be less, and that's where your DDMA is going to be absorbed. So if you have decreased absorption, that can slow the process and cause a longer time to death. We have seen that some of the younger patients who have very hardy hearts and cardiovascular wellness have a delayed time to death. Of course, the heavier individuals, alcoholism, where they're, or tolerance to opioids, where they've already had this kind of exposure to respiratory and cardiac CNS depressants. So in those patients, you would have to either anticipate and recommend to the doctor that they add the Phenobarb component, or tell the family that, there might be a longer time to death, and it will still occur, but it might be a little bit longer. So next slide, please. Okay, so we talked about the options for those who can't swallow. And again, as a pharmacist, this is one of the things, and we're sort of getting cart before the horse, because one of my slides will say, the doctor calls you and says, how do I prescribe this? Or you receive a prescription and you have to anticipate, gee, do I have a person who's able to swallow? Do I have a person who needs some special treatment? So asking those questions is very important. Whether the patient needs a feeding tube, will be transitioning into a feeding tube situation, or has an NG tube, nasogastric, a PEG that's placed, or a J tube. And all of those will be able to administer the medication. They'll just need syringes that fit into their J tube, and the mixture will need to be able to be mixed into a liquid that can be put through that. It's still considered self-ingestion as long as the patient can push the plunger themselves, or if they don't have the ability to push the plunger, that they could open a stopcock. So it still has to be self-ingestion, and that's a fine line to have to walk. Next slide, please. One area that I think few people have had experience with is rectal administration. So people who don't have a functioning GI tract and or can no longer swallow fluids could use a rectal administration. They have to know that there is special catheters. Don't use a Macy catheter for med administration because that actually clogs. So that's a subtlety. And then there's some information about some of the objects you would need for administration. Next slide. Okay. Some of the barriers for people being able to access the medical aid in dying in any state is that, again, you have to obtain it from a compounding pharmacy. And then there's the cost. So since Medicare and federal groups do not cover this, the cost of the medication is about, depending on the pharmacy and their cost, is about $750 for a DDMA preparations. Some pharmacies and some healthcare systems that are faith-based do not allow dispensing of medical aid in dying. So that can also be a barrier. Again, it's also a freedom to decline to be part of this. So some pharmacists can personally not decide not to dispense. And Dr. Grube's going to have a very interesting story later on about that. And then the waiting periods have been a really big barrier in other states. So kudos to New Mexico for seeing that and learning from our experiences with your 48-hour time period between prescribing and filling. It gives a little bit of time for perspective for the person to have to wait and before they fill it. We have just in California decreased ours from 15 days to 48 days between requests, and then they can fill the prescription. So we also are moving in that area in time delay. Next slide. Okay, so really for the pharmacists in the area and for people who want to understand our role in medical aid in dying, we're going to go to the next slide. And I've already referred to this in certain ways, that we are a resource. We are the ones who know about medications and how they're compounded. We have a due diligence to receive the prescription, assess whether it's really appropriate the way it's written. And in some compounding pharmacies, they actually get a copy of the evaluation from the physician that looks at whether the patient qualifies. And that's a due diligence that the compounding pharmacy has taken upon themselves to make sure the patient qualifies due to the law. It's highly recommended that the pharmacist work very closely with the physician's office. I referred to this earlier, verbally verifying the script and clarifying those specifics that we talked about before. And we'll get into that a little bit more. Obviously, the role of the pharmacist is to compound the prescription and then counsel the patient and the family. And that's where a lot of what I do is very personal. And I would love people to consider how they want to do this. And then, of course, dispensing the medications is one of our areas. So next slide. Obviously, pharmacists have different comfort levels. I work very closely with a partner, we job share, and she says, thank goodness you like to do this because I could never do this, just because her emotionality would get in the way. So one way to increase your comfort level is to work with a pharmacist that's already done this. You can actually participate in a counseling session with the patient's permission, the patient and family permission. And there's also a pharmacist to pharmacist line for compassion and choices that you could get some advice. Having that good working knowledge of what the medications do can really increase your comfort level. And that's what we're here for. And then there's online guidance. End of Life Washington, Oregon and Washington led the charge with this whole medical aid in dying movement. So they've got really great resources. And I've tried to include a lot of resources in this slide deck. And then just to know, if you aren't drawn to this work, there is no shame in that. As Dr. Grube said, shame is not involved. This work is not for everyone. I happen to really take value in it. And I hope at the end of this slide deck and presentation, you'll know that there are really great rewards to doing this. Next slide. Okay. Also, there are different styles to doing this. You do not have to be a super emotional person. You can be matter of fact. You can decide to bring all your empathy and, you know, really sit and support the person almost in a social worker type style. It doesn't matter. And just be ready for the patient's different reactions. Some patients, they have very little emotion when they hear about the medications. They're straightforward. And then what's amazing is there's often a lighter atmosphere than you could ever imagine. There's joking going on and just a sincere feeling of relief that there's this option available instead of sitting in the unknown of how painful and terrible this illness might get to be. And then there's the patients and families where as you present, here's the medications, here's talking about the medications down to the moment that you will take them, it really hits people and you will hear the silence. If you're on the telephone, you can sense that people, it's really hit them. And it's okay to say, I understand, this is really real at this moment, and we can wait a moment. And I put that note in red at the bottom of the slide. It's okay to tear up, and you can still be professional. So, all right, thanks, Matt. Consultations are very important. We know that in this time and in New Mexico, where you've got this geographic spread, it may not be able to be done in person. So telehealth is a very good option. I highly recommend a video visit. I use bottles and vials to show the patient this is what it looks like, this is what it's going to be, and that really helps the communication. If they have the medication in hand, they can really match up what they're seeing on the screen with what they have in hand. And it's really important to have communication with all the members of the healthcare team, the patient, the family, and if there's a hospice nurse around, to also include them or the hospice team. Next slide. Okay, of course, when we do the consultation, we're going to talk about this is the purpose of the visit. We're reviewing the medication instructions. Here's the time sequence, what to expect. How do they dispose of this medication? What if they don't end up taking the medication? What do they do with it? Using a patient handout to really make it clear and understandable, especially when they walk away from talking to you, because it's going to be kind of a blur for a few minutes there. And the average consultation does take a little bit of time. It's not going to be your 1 or 2 minute consultation at the window. It's going to be a 20-minute, 30-minute consultation at the minimum. Next slide. Support materials, I cannot stress enough how important it is. We're going to show you an example of a patient brochure. I've also embedded it into the slide deck. A timeline, a picture version. A picture is worth 1,000 words, and it is so true. Really giving them the details that you're going to talk about, including the time to death, the phases of death, and what it'll look like. I think some places, since patients are taking the medical aid in dying medication, clinicians sometimes forget to tell patients and family what the process of dying looks like. So we do have to include that. Even as pharmacists, we might be the only ones talking to them about that. And then the support materials, your electronic health record, and documenting exactly what you said to the patient is very important. Okay, here's this picture that's worth 1,000 words. And this is from Kaiser Permanente, Northern California, but we're happy to share it. And this, we have a full brochure, but I always take patients right to this page and I say, this may look very complicated with all the bottles and stuff you have around you right now, but these are the 5 easy steps. And I always refer back to the picture. The pre-medications are right there in your hand. They're very tiny tablets. Here, let me show you. Here's how you prepare the mixture, and it shows the person taking it in the end. And of course, this is all supported in the brochure with more details in written manner. Next page. So, Dr. Grube talked about how the varying life-ending mixtures are there. So depending on which mixture is chosen either by the physician or with advice by the pharmacist, there will be some kind of mixture, mostly including digoxin, diazepam, and morphine, and then the rest are are variable. So knowing that the powder has a 6-month expiration just by law of how we do compounding, the patient may very well survive past that first 6-month dispensing and need a redispensing, but they need to know about that. If somebody needed a pre-mixture that was liquid, it's a very short expiration period and it's only 2 weeks. So that would only be prepared when the patient was ready to ingest. Pre-medications can be variable. The tablets are very easily crushed, but if you know a patient needs liquid, then those should be provided instead. And then there's obviously administration supplies, including a measuring bottle. We provide a wide bore straw for patients who it's easier for them to drink quickly through a straw, and then perhaps a syringe if needed, and then the instructions. Okay. So here's what happens in the typical mixture of DDMA. And again, this is not with the phenobarbital added, but it is one mixture that's used. And this is the timeline I use to talk to the patients, that they need to know to take the medication within 2 minutes. And the importance is that a lot of patients fall asleep in that 2-minute time period. So if they don't, soon after taking the medication, they will fall asleep. And I tell patients and family, this is a nice, peaceful sleep. And then you will progress into a coma where if we tried to shake you awake, we could not get you to respond. And that's called a coma. And you'll get more shallow breathing. You'll see the changes in breathing that a person normally transitions to. And then within, some patients actually pass away within 2 minutes. So I warn patients about, or family about that, and patients, because, you know, we talk about this 2 hours, but what if they say, oh my gosh, I didn't expect that to happen so quickly. So we do need to know that. The average time to death is, you know, in our experience of hundreds of patients, is less than 2 hours. 85% of the time patients pass in 2 hours. And then we still have to warn that it might be a prolonged time. Next slide. Okay, so I think it's really important as pharmacists for us to know what is going on with DDMA or DDMA pH. And some patients want to know all the ingredients and what they do. Some patients just sort of want a summary. So you can do it in a couple different ways. Why is it important that they take it in 1 to 2 minutes? Just telling a patient that they need to, I don't think is enough, because they don't understand the importance. So the idea that they'll fall asleep quickly, we don't want them to fall asleep before they get the full dose. And I think that's really important for them to know. And some patients worry about, oh my gosh, 1 to 2 minutes sounds so short. I tell them they can practice with the 3 ounces of water the 3 ounce amount that they would need to ingest. They can practice that and be reassured that they can do it within 1 to 2 minutes. With ALS patients, I say that is going to be a big sign of when you need to just, you know, to determine your timing on this. If you get to the point where you can't swallow, then we either have to look at not ingesting orally and having a J-tube placed, or you have to consider if it's your time. Pre-medication, why is it important to take pre-meds an hour before? Metoclopramide is common pre-medication, and I tell patients this one's really important because your gut is slowing down as your illness takes over, and that happens with all of us. And the metoclopramide or Reglan helps with the gut motility, getting the drug where it needs to be absorbed. It's really important to take the meds 1 hour before. Some patients, when they're getting towards the end, they just want to skip it, and I say this is really important. We don't want you to have nausea and throw up the life-ending medication. So again, reiterating why these steps are important. Then we discuss the DDMA mixture and how it works. And usually patients are familiar with names like diazepam and reminding them that that's Valium, and morphine, the M component. You know, they know that's a pain medication, and that at the end of life, people are on these higher doses, so that both of those can make people drowsy, slow their breathing, and slow their heart. And then I tell them we've added in other medications like digoxin that's been used for fast heart rate, and that slows the heart, and then also amitriptyline. And they seem to understand that we're moving in the right direction of slowing the heart and slowing the respiration down. And that gives them an understanding of this. What's really neat is if you watch the videos of how the Oregon and California docs developed this, I can really honestly say that they did such a great job of having patients willing to be monitored by an EKG and look at what their hearts were doing and look at how they passed away. And we've really fine-tuned this mixture. They might have heard about old mixtures that had, or the secobarbital that took 20, some old mixtures, there were outliers that took 24 hours. Don't worry, this has been fine-tuned. And hopefully in New Mexico, they haven't heard a lot of these because you're going straight to the better mixtures. But I tell you, people look on the internet and they hear these things. Really important, the last box on the bottom, what will the mixture look like, taste like? You mix it with clear juice. It's usually, ours is flavored with an apple flavoring. I tell them, look at this, it's a powder. It's gonna be bitter. It's not like a tablet that's coated to prevent you from tasting the medication. So it's gonna be bitter. You have to know that. Mix it with a juice to make it sweet. It's going to be a little bit gritty. So knowing that, I want you to be prepared, because I don't want you to say, yeah, nobody warned me about this. You stop and then you don't finish the mixture within 1 to 2 minutes. So I say, just know it's going to taste a little bitter. You can mask that bitterness, and some patients have that burning of amitriptyline. You can chase it down with a little bit of sorbet, a popsicle. Sometimes sorbet is like, what's that word? Sherbet, but we try to do the non-milk component so that it's cooler to the palate, and also just in case milk would change the absorption. And there is an alternative option that some patients very much welcome, which is an alcohol chaser. You do have to be careful if the patient has a seizure risk, because with amitriptyline and alcohol, you could induce a seizure. So if they have any risk, that would not be a recommendation. But the alcohol can actually chase away that bitterness. And some patients are so thrilled that they can finally have permission to do a little shot of clear alcohol. Next slide. Okay. This is very small, but we'll provide this. This is an example of an education sheet for pharmacists. So they have this kind of information available to them in more pharmacist language than in patient language. And it pretty much covers everything we've said in this training. So next slide. All right. This is my reward slide, which I talk about. It is amazing to be able to provide people with a choice. That we look at the feedback we've gotten from patients and family, their fear of losing autonomy and choice and control in a severe illness is the reason people choose medical aid in dying. Just so you know, about 30% of patients who receive the medication never ingest it. But that doesn't mean that they don't get a huge benefit from having gotten the medication or the prescription for the medication. It's a huge relief to know it's available. As a pharmacist, you are supporting both the patient and the family, not only with information that helps them, but with emotional support. And as I said before, that can take many forms. And I must say that it's some of the most meaningful work I've ever done. And I do wear a lot of hats in my role in what I do right now, but this has been one of the ones that have paid back. I've been able to pay back and really feel like I've added benefit to people's lives. And now I'm going to hand it over to Dr. Grube to tell you a very real story about a patient.
Thank you so much, Dr. Gess. That was really excellent, as you always are. I'm going to skip the story because it's an interesting story, but we don't have enough time for questions. So I think we'll go ahead and I'm going to turn it back over to Matt, and we'll be ready for questions in the last 10 minutes or so.
Wonderful. Wonderful. Very quickly, I just want to let folks know quickly about some other resources. One being that there are 2 other presentations that now live online, both on the End of Life Options New Mexico website and on the Compassion and Choices website. So if those topics look interesting to you or answer some questions that maybe came up for you during today's presentation, feel free to go there, as well as a end-of-life symposium that's coming up in Las Vegas in December. There are a few spots for in-person registrations available, but infinite numbers of folks who can join virtually. So if that interests you, please take a look at that as well as Barrick, you want to quickly talk about end-of-life options New Mexico, and then I'll get some
Well,
questions.
absolutely. Just to let people know that we have formed a nonprofit corporation modeled after the kind of programs that we see in California, Washington, Oregon, and other states that have been doing it longer. Again, it's available on our website. We ultimately will be doing public education and outreach to help inform the population, not just about medical aid in dying, but about advanced care planning and all the options that are out there, as well as these kinds of clinical presentations. So take a look at it. We really appreciate our partnership with Compassionate Choices to help us put these sessions on. I would also just quickly mention that access to medications is an issue here in New Mexico. We are working on seeing if we can't use some state monies through the Medicaid program to support the cost of medications, as well as that End-of-Life Options New Mexico has already supported one individual who could not pay for their medications. And we will do that as requested and as we have funds. So again, thanks for the opportunity to participate. We look forward to the continuation of this good implementation that's going on in New Mexico.
Wonderful, thank you. All right, let's jump over to our questions. There are some great ones, so I'm going to try to lightning round these as quick as we can so that we can get a lot of them answered. The first one being about expiration dates with the medication and the prescription. How long after an expiration date would you recommend safe use of these medications? When do you discard and get another supply? How does that work in practice, Dr. Gess, when a person has had the medication for a period of time and needs a new one dispensed, for example, if they were to have it dispensed early?
So yeah, we do a lot of early dispensing here in California in my system, which is Kaiser Permanente. I know other places they don't dispense until the patient actually has set a date. So that's one way to avoid expiration, but it is as a compounded item, the DDMA PH only has 6 months expiration. So if it were in the possession of the patient, we usually have them discard that and make sure that their new supply is clearly the new supply and they need to get redispensed. We would hate for it not to be potent enough that it would lose potency and not work. So they do need to get it redispensed. The pre-medications usually don't need redispensing unless they were dispensed in liquid form.
Wonderful, thank you. A question around counseling families, both for Dr. Gess and Dr. Grube. Sometimes with death, there's a loss of bowel or bladder control. Do you counsel family to put down chucks or waterproof pads under a person? Is that involved in the counseling piece?
I think it's a good idea to do that. And as it's turning out now in Oregon, and I think we'll be seeing the same thing in New Mexico, most of these patients are hospice patients, and so often a hospice nurse is present. So this is kind of the thing that the hospice nurse knows to do and knows to counsel, but it's never harmful for any of us to remind the family that that hygiene matters and simple to do. And of course, these people have been sick for so long, they're already kind of prepared for that, or they may already have the chuck in place.
Yeah, just to add to that, I always check to make sure that patient has hospice, that they've decided to have a hospice nurse present or not. If they're not going to have a hospice nurse present, I counsel a little bit differently and give them more information. I actually have a handout that's typical signs of passing away that I can choose to use with the family if that would help. So
wonderful, thank you. There's also a question about what your experience has been when it comes to support for dispensing medications around aid in dying. The difference between independent pharmacies versus large pharmacies like a CVS or a Fred Meyer or a Walgreens. Dr. Grube, for example, in the kind of history perspective of things, what type of pharmacies are typically dispensing medication now? What have in the past? How's that looked?
Well, it's absolutely different now because it's only compounding pharmacies. So the ones that you mentioned are not compounding pharmacies. Most compounding pharmacies are independent, although there are some associations of compounding pharmacies. Um, and in Dr. Gess's organization, of course, in Kaiser Permanente, they're large enough that they can actually have that. So now it's pretty much independent pharmacies, compounding pharmacies. Historically had been the big chains, but that's really no longer the case. Susan?
So if a small pharmacy gets a request, what happens here is that they know or need to know who are the compounding pharmacies that would do that. So they can refer to the compounding pharmacies.
Wonderful. There's also a specific question about bariatric surgery and a person talking about a patient who is post bariatric surgery and has, a differing level of absorption. What type of pharmacy preparation considerations might happen because of that?
Well, I think context matters, and historically, person having bariatric surgery might have been obese. However, depending on what kind of cancer they had and what kind of weight loss they've had from their cancer or their disease would probably help sort of allow us to think differently. But as Susan mentioned, the anything that has to do with the GI tract does need to be thought of as a red flag, and so you would need to think about that and see how have their other medicines been absorbed or been effective, how efficacious have their regular medications been in their last couple months. All those things you would need to take into account.
Yeah, and definitely the phenobarbital addition would be a smart move because it's just a more potent mixture than the DDMA. So that would be one factor. One of the concerns in bariatric surgery is not to use extended release items and to always use immediate release. So the good news is we're using immediate release items. They should have a percentage of their intestines still available for absorption. The situation I could see is if you have a person who's had bariatric surgery and now is obese and has a cancer of the colon, it gets quite complicated, and that case would be very individual. It might be something to contact ACAMAID, ACAMAID physicians to see if anybody's had that experience.
Wonderful. There's also a couple of questions about family members and what happens after a person dies with those family groups. One being, is there any other sort of counseling that families get when it comes to grief that's specific to aid in dying, or is this something that hospices typically handle and speak to? And then with that also, how do families typically report what happened after taking the medication, for example, if there's not clinicians present? So just maybe a little bit of a gestalt, what happens after question.
It's very mixed, of course, as is everything. That's why it's so important, as Dr. Gess mentioned, that hospice be involved because they can really handle these situations. It's unusual. I think it would be atypical that a particular type of grief counseling needs to be done for these patients, although there are exceptions where it certainly might be necessary. And the thing about this, though, is that this has been something that has been talked about and planned for some time, usually. The individuals that I prescribed for, they knew this, they would want to do this a year from now if things didn't go well. So, but there are occasions where maybe not the family, it doesn't all get along, or the individual who used the medicine didn't want some family members to know. So each of those situations is unique and sort of needs to be handled on a individual basis.
I agree.
Well, I believe that takes us to the end of the hour. We want to be respectful of folks because we know that many of you are joining us maybe on your lunch or in a short amount of times that you have. So again, I want to remind folks that the recording of today's webinar will be available afterwards if you want to share that with other folks. But mostly, I just want to express my gratitude to Barrick, to Dr. Grube, to Dr. Gess for presenting today and enlightening all of us and letting us listen. It was a pleasure to be here in the background and to be a part of it. And also, maybe even more so, gratitude to all of those who joined today, who saw this as an important part of whatever your practice or your life entails. So thank you to all of you for joining. We hope that it was of value to you, and know that End of Life Options New Mexico and Compassionate Choices are both here to help and to answer your questions as they arise, and to help you be successful in supporting the people that you serve. So thank you to everyone, and have a wonderful rest of your day.